I'm Rena Callahan. I'm a breast medical oncologist at UCLA.
I'm Aditya Bardia, also breast medical oncologist at UCLA.
Great. So, Dr. Bardia, we're here to talk about HER2-positive breast cancer, and there have been many exciting developments and FDA approvals that I think are practice-changing. The question is how and when are we going to change our practices? So for you, with the FDA approvals of Enhertu, both in the neoadjuvant space based on DESTINY-Breast11 and the adjuvant DESTINY-Breast05 data, are you changing your practice? Have you used this now that it's FDA approved?
Yeah, no, absolutely. So to answer your first question, when would we change practice? The answer is now. I think the data are very compelling, so that would provide us the reason why we should change practice. And in terms of whether I have used the data from DB05 and DB11 in clinical practice, the answer is yes. Now, trastuzumab deruxtecan is FDA approved both in the neoadjuvant and adjuvant setting for patients with HER2-positive early breast cancer. So let's just talk about a couple of points related to these studies. The first thing to remember is that these studies were done in the high-risk patients. So if we talk about DESTINY-Breast05, which was looking at trastuzumab deruxtecan in the adjuvant setting, it was for patients who have high-risk disease, the multiple positive lymph nodes or tumor size that was more than 5 centimeter in size, or patients who have matted lymph nodes. So it's for the patients we are really worried about from a clinical perspective. And if we look at DESTINY-Breast11, similar, slightly less high risk, but again, it was for patients who have high-risk disease. And in that setting, they looked at trastuzumab deruxtecan, neoadjuvant for 4 cycles, followed by a TC for 4 cycles, and compared that to ACT and found that the PCR rate, or pathological complete response rate, was higher in the T-DXd arm as compared to T-DXd, as compared to ACT. Now, this trial also had a third arm of T-DXd for 8 cycles, which was stopped early. So if I were to use T-DXd, I would follow this trial in the neoadjuvant setting, meaning using it for 4 cycles and then after that using TC. And the advantage is it gives us an anthracycline-free regimen that we can use in the neoadjuvant setting.
Right. And the pathologic complete response rates, I thought, were just, through the roof. Very, very high overall. I think it was about 67%, extremely high in the hormone receptor negative population, upwards of 80%, but also very high for hormone receptor positive. So I think that it covered, the patients that we see. To your point about high risk, while in DESTINY-Breast05, it was a higher risk patient population than in the Catherine trial when T-DM1 was compared with trastuzumab. But would you think that anyone who does not achieve a pathologic complete response is high risk, even though it would fall outside of the trial eligibility criteria? Or are you going to stick to those patients that fall within criteria?
So ones who fall within criteria, yes. So that would be a patient who gets neoadjuvant therapy and then despite that has significant residual disease. The first drug I would be thinking about would be trastuzumab deruxtecan to improve their outcomes. If a patient has minimal residual disease, let's say 0.1 or 0.5, I would still use T-DM1. It's approved in that setting. And, from a safety perspective, T-DM1 versus T-DXd quality of life perspective, many patients would tolerate T-DM1 better. The middle zone, I think, is tricky. So what if a patient has 1 positive node or, say, 3 centimeter tumor? I think it's worth a discussion. It'll be off-label use, but it's worth a discussion with the patient. And I think that's when you look at other characteristics. What was their baseline risk before starting neoadjuvant therapy? Am I talking to, say, a 35-year-old versus, say, a 65 or 70-year-old? Because the safety profile can vary based on age and also their tolerability. So I think all of the other factors, comorbid conditions, that would play into that decision making.
Right. I completely agree with you in terms of looking at where they started, because we know, based on older data, that if a patient achieves pathologic complete response, if they're starting with much higher stage disease, they still have a higher chance of having recurrence or relapse. So we need to keep that in mind.
Fully agree. And
Yeah.
just to emphasize this point, it's clearly seen from studies, patients who have PCR, they have excellent outcomes, but PCR does not mean 0% risk of recurrence. So the question is, who are the patients who, despite PCR, can have risk of recurrence? And you rightly pointed out, it's the one who have high risk at baseline before starting neoadjuvant therapy.
Right. So, now that it's FDA approved, we want to use this, and I think, at an academic center, we are going to implement this and implement it very quickly. I am interested to hear your thoughts on the rollout in the community. Do you think that this will be challenging for community oncologists to do, either based on just feeling comfortable with this dramatic change in therapy, or due to logistics? Or do you think that we're going to see the uptake pretty quickly?
I would think more the latter, because if this was, say, 5 or 7 years ago, many oncologists were not familiar with the use of T-DXd. But now T-DXd is approved for HER2 positive metastatic breast cancer, HER2 low and ultra low metastatic breast cancer. It's approved in a couple of other cancers as well. So most oncologists, I would assume, have some experience with T-DXd. And if you have experience with T-DXd, then you would feel comfortable using it in the early breast cancer setting. You have to be mindful of the toxicities, nausea, use of a 3-drug antiemetic regimen. One patients, they might have alopecia. We don't know whether cold caps would be effective or not. And then monitor for pneumonitis, which is a known but serious risk with T-DXd. So you have to monitor for that.
Right. So do you think that the monitoring schedule for interstitial lung disease is going to present any challenges? I think in the neoadjuvant study, it was very frequent, but they only received 4 cycles of T-DXd. But in the adjuvant setting, where they're getting 14 cycles, on average, they needed to do chest CTs, or they did in the study, approximately every 12 weeks. Do you think that that's realistic for the number of patients that would be treated adjuvantly?
And I think that's where the risk benefit comes in. For a patient with high risk, you're willing to take that risk in terms of getting those additional scans because you want to prevent recurrence. If a patient has low risk disease coming back to that 0.1 or 0.2 centimeter residual disease, that's where the risk benefits might not be favorable. And to that point, that's why personally I tend to prefer T-DXd in the neoadjuvant setting over the adjuvant setting, because A, it's fixed duration, 4 cycles of treatment. The rate of pneumonitis was very low in DESTINY-Breast11 when it was used in this fashion. And it's much easier to monitor. And if a patient has PCR, that's associated with better outcomes.
Right. So, with neoadjuvant, it's great, and they have a very high chance of getting a PCR, but what if they don't, right? And you've used 4 cycles of T-DXd and probably 4 cycles of THP, then what do you do with a non-pat CR?
Yeah, and
Yeah.
good question. And that's a tough situation, because you can certainly use TDM1 in that setting, but you just have less confidence. If this patient has residual disease despite T-DXd, despite TC, would TDM1 mop off any cells that still might be there? But I think that is an option we can consider. If you're really, really worried, the other option would be to use AC in that situation, because the idea is, I want to prevent recurrence. I've used, the best agents I have. What else can I use to prevent recurrence in this patient? And so it's a patient-centered discussion, but that's where I would potentially consider AC.
Right. And I think, though, that there are certainly, I agree, some patients that are resistant to some extent, but then there's some patients who I think just haven't gotten it for long enough, right? And especially those patients with very high volume disease, 4 cycles of T-DXd just might not be enough. So I think if you get that sense that, oh, it was really working, but maybe we just didn't give it enough, I think one could make an argument to use a bit more after surgery, although there's no data to direct this
That's a great
right
point.
now.
That's a great point. So just to that, I would love to hear your opinion as well. Let's say you have a young patient, 35, 40-year-old, give 4 cycles of T-DXd, and then you give TC, and there is residual disease at 0.5 or 1 centimeter left, and the patient started with multiple positive nodes, 5 or 6 centimeter tumor. So very nice response, but still not PCR. What would you consider, or what have you heard in tumor boards?
Yeah, so I think that, there's this concept that, oh, you gave the neoadjuvant and so someone is resistant. But if you could see that there was this response to treatment, I think that it's valid to give more of the same. So I would consider giving more. Uh, I have not run into that yet, so I think that our tumor board will get very interesting when we start using it more and then have to make these very difficult decisions about that. But if we see a lot of treatment effect, and also just we follow our patients along the way, right? So we get this sense of whether they're responding to something and what they're responding to, especially when there are kind of 2 different treatments that are given. Sometimes we can get a sense of their response to even the individual components of treatment, especially if we're doing some type of interim imaging.
That's true. That's true with the breast MRI and
Right.
seeing.
I tend to do interim imaging after 4 cycles of neoadjuvant treatment. I think that just helps me make decisions not only in the neoadjuvant setting, because sometimes by that time point or a little later on, they're having a lot of toxicity, and it helps us know how hard to push sometimes, and then I think can inform decisions after surgery as well.
Yeah, really agree.
So
We almost made a guideline based on this a discussion, which is, at the end of the day, in the adjuvant setting, we want to prevent recurrence.
right.
And one of the things that is not captured often in clinical trials is the patient history. So, if there's a patient who's included in an adjuvant study that has residual disease, that's a heterogeneous population. You're including patients who had response to neoadjuvant but not complete, as well as patients who didn't have much response to neoadjuvant.
Right.
But the treatment trajectory of those patients is very different. So in clinical practice, you learn from your past. You see how the patient is doing. That'll dictate your future. So, to your point, if a patient had a very nice response to T-DXd and you just feel maybe more T-DXd would be helpful, that's certainly very reasonable. As opposed to a patient who got T-DXd, TC, not much response, then you need a different strategy.
Sure.
Like AC or something.
Do you think one thing that's come up in just when you look at subset analyses of studies is PAT-CR, or does it matter how you get there? Is there any part of you, knowing how well T-DXd performs in breast cancer across malignancies, which makes you think that you want to give a HER2 positive patient T-DXd?
In general, yes, it's the most active agent we have. And in part, that's why I tend to use it in the neoadjuvant setting, because I feel a patient with HER2 positive disease should receive T-DXd. It's just so active.
Right. So do you think I felt that some of the data was compelling from DB05, specifically with regard to CNS metastases, as the first site of relapse. We didn't see that with TDM1. So, one of the struggles that I have is in limiting to neoadjuvant treatment is 4 cycles enough, or do you really need that longer duration to prevent CNS metastases, which
That's
is
a
something
great
that's terrifying, right?
Yeah, no, absolutely. Great question. We just don't have the data. So I think we definitely need more follow up. One limitation of Destiny-Breast11 is we've not seen long term EFS and OS data as compared to Destiny-Breast05. So absolutely, we need more follow up. And if we consistently are seeing that there's more CNS mets or less CNS mets in one group, I think that'll further refine clinical practice.
Right. How do you think that, we've spoken about this and amongst colleagues and then in the community, I think a lot of times what we do is informed by an N of 1. Even though our studies have thousands of patients, if you have a negative experience, I think that that leaves a mark. And we're treating patients with early breast cancer, trying to cure them. And so whenever you see major toxicity or death even, I think that that has the potential to scare some oncologists. Of course, we don't want to harm our patients in that way. I personally feel that we have to weigh it holistically. Are we preventing deaths overall? And I feel comfortable with that, with Destiny-Breast05. But what do you think in terms of, how general oncologists will feel about the potential? And there were a couple deaths, due to interstitial lung disease.
Yeah, no, it is a
Yeah.
challenge because if you're preventing a death, you don't see that.
Right.
But if there is a death that happens, you do see that. So absolutely, it does have an impact. I think we stick to a basic oncology principle: use it in the right setting, weigh risk benefit, know about the toxicity, and monitor it for toxicity. So as long as we are following those principles, and that's the best you can do for a patient.
Right. I think so. And with all, any death we should try to prevent, but with very, very small numbers, I think that that's something that we see with chemotherapy,
That's correct.
right?
Absolutely.
That's the part of what we have to deal with that. Um, so moving on then to uh, Destiny-Breast09.
Mhm.
So now, that carries an FDA approval to use T-DXd plus pertuzumab in the first-line setting for HER2-positive metastatic breast cancer. Are you using that across the board? And if not, what criteria are you using to decide who gets it?
I think it's a good question, and my answer actually has changed after ASCO. So if you had asked me this question in, I don't know, March, April of 2026, I would be saying, well, T-DXd is approved. We also have THP, and we need to individualize for a patient who has brain mets or visceral disease. We should be using T-DXd because it's very active. It can reduce their symptoms. But it's also reasonable to consider THP for some patients. And then at the time of disease progression, you can always use T-DXd. But what was striking at ASCO was a subset analysis which showed that the proportion of patients who received T-DXd plus pertuzumab had more, not only complete responses, but also deep partial responses, meaning more than 90% reduction in their tumor. And that was associated with good long term survival in terms of 2-year PFS. So, at the end of the day, if we can get close to a complete remission with a drug, that's very valuable. And in Destiny Breast 09, that just didn't happen after 6 cycles. So I think that to me does say that for an individual patient, we should use T-DXd, see if we can get to a CR or a deep PR. And then after that, whether we continue T-DXd forever versus at that time consider HP maintenance, I think is an open question, but I would want to get a very nice response if I can for an individual with metastatic disease.
Right, absolutely. I've heard a lot about, and there are ongoing trials with fixed duration of T-DXd, and while that is appealing, I tend to treat now to best response and, just try to get a little more and a little more and a little more. And I think most patients are up for that. So that's where I think we bring the patient into it. Patients want to see responses. And so when they see their scans improving, I have some of them ask me, what do you think? Is it going to improve more on the next scan? What do you think? And yeah, it very likely will improve. And so we can get a lot of patients into that deep, deep response where they do better in the long run, but I think that they also feel better while they're on it. Because I've had patients who are very, very symptomatic from their disease, and as you lower the disease burden, they feel better. They feel completely different. Even ones who initially were skeptical of chemotherapy, I'm too sick to get chemotherapy, that
Yep.
kind of thing, just a complete turnaround. So
Yeah, no,
I
fully
think
agree.
that's
Fully agree. Disease control is the best way to palliate
right.
the disease, because
Yes.
to control the disease, you'll control the symptoms that are coming from the disease.
Right, absolutely. Are there any patients for whom you won't use first-line T-DXd? So what if, now that we have these FDA approvals in the early breast cancer setting, what happens, for those patients, hopefully a small number, that relapse despite that? Will you use T-DXd again? Uh, what does the disease-free interval have to be?
Absolutely. I think both of these factors. So the proportion should be very small. And in general, in our clinical practice, if you're seeing a patient with metastatic HER2 positive disease, it's usually de novo metastatic disease. Given the success of our neoadjuvant adjuvant therapies in general, we are not seeing relapses. But if you have a patient who relapses despite T-DXd, then we look at the disease-free interval like any other drug. And if it's more than 12 months, I would feel comfortable reusing T-DXd. But if it's 2 or 3 months, then I might consider another agent. The other thing I would consider in that setting, which we should always do, is get a biopsy, because you just wonder, did something change as to why this patient is having recurrence despite T-DXd? So just getting a biopsy and consider genomic sequencing can be valuable.
Right. And I wonder, with the theoretical patient who relapses post T-DXd in the early setting, of course, there are going to be some patients that develop resistance. And of course, we need to do a rebiopsy. But maybe they had metastatic disease the whole time. I don't do staging scans for every patient with her early HER2 positive breast cancer, but maybe I should. For those stage 1 and 2s, node negatives, I usually don't, but I'm sure that there are a portion of those with de novo metastatic disease that we just don't know of.
Yeah, I fully agree. Absolutely. Because, even patients with stage 1 disease can have recurrence, which means that there could be disease outside of the breast. And if we look at ctDNA, that can also be seen in patients with stage 1 disease. So we're just getting more evidence now that even with patients with stage 1 disease could have disease that potentially could be metastatic.
Right, right. So would you, in the metastatic setting, are there some patients for whom you would use, just say, hormone receptor positive, right? After speaking with the patient, just say she has no contraindications, decent functional status, no underlying lung disease, anything big like that. Are there some patients where you would use THP followed by endocrine therapy with HER2-directed therapy and potentially palbociclib, based on the Patino regimen? Where does that fit in?
So I have been using the patina regimen when using HP with endocrine therapy with actually good success. I've been pleasantly surprised. Patients are tolerating the combination well. Now, these patients were who got THP before we had the results of DESTINY-Breast09 and are on HP maintenance. And I've just added the palbociclib. So I think that's a very reasonable regimen to consider if a patient is on HP maintenance. Is there a patient I would start with THP upfront? It would be someone who has ER positive, HER2 positive disease, where we would use a fixed duration of THP and is asymptomatic. In general, for anyone who is symptomatic, I would consider T-DXd. But if a patient is asymptomatic, the question is, would I impair their quality of life with the use of T-DXd and the side effects versus can I use a drug for a fixed duration and then just do HP maintenance? It's a discussion. I'm not saying all asymptomatic patients should get THP, but it's a discussion for someone who's asymptomatic, THP versus T-DXd.
Right? Or potentially treat to best response, right? And then use an upgraded maintenance strategy. Do you think that there's a role for HER2 Clim05 to add tucatinib in the maintenance setting, or do you think it's just been completely overshadowed by data such as DESTINY-Breast09 and then patina?
Yeah, I think more the latter. We'll see. It's not approved at this time. At some point, tucatinib could get approved, but the enthusiasm in general is low, especially for hormone receptor positive, HER2 positive disease. There, I would rather use palbociclib. For hormone receptor positive, hormone receptor negative, HER2 positive disease, if a patient is on HP maintenance, I guess that's where one could potentially consider tucatinib.
Right, exactly. I mean, there was all of this excitement about, crossing the blood-brain barrier, and I think this is where sometimes we are, as, physicians, oncologists, we have to look at the data and we can be proven wrong, right? Because initially, we didn't think ADCs got into the brain. And so clearly we were completely wrong with T-DXd's extremely strong data with treating CNS disease, just incredible responses. And now we have the data that says that prevents that from happening in the first place. So while tucatinib is this CNS active agent, we just didn't see that incredible result, at least in HER2 Clim05, in terms of preventing CNS metastases. So I was a bit underwhelmed by that, but at least we have more options.
Fully agree. Fully agree. And that's why for a patient with brain mets, I would still use T-DXd. I would not use THP and HP tucatinib. It's just the activity we've seen with T-DXd.
Right, exactly. So do you find that patients tolerate T-DXd pretty well or start to fatigue from it over time? And do you start giving it in a different way? Spreading it out, lowering the dose, those types of things.
Yeah, both of those. What I've seen is some patients who are not able to tolerate T-DXd for either fatigue or nausea. If you use a lower dose, that tends to help a lot. So it's more about using the right dose rather than the highest dose, and you need to refine that for an individual patient. But there are others who just sail through it, who have no problems at all, and can just continue T-DXd.
Right.
Especially when you're using T-DXd first line, which could be 2 years, 3 years, 4 years, maybe even longer. Here and there, it's reasonable to take a treatment holiday. If a patient has, again, the CR or deep PR, it's very reasonable in that situation to give a break of treatment and then you can start again.
Right. And, I know that this is controversial, but we can't ignore that there are ctDNA tests that exist. And especially for my patients who insist upon treatment holidays, that is something that I've started implementing. I have one, actually, who was taking a treatment holiday. We agreed on 6 weeks, and she just wanted to extend her holiday, and the ctDNA turned positive, so she's back. She's back. But I'm glad that we should. Yeah, exactly. So.
And I guess in that setting, then you use a ctDNA assay that's sensitive, more like an MRD assay,
Yes.
because you want to detect the lower limit of ctDNA.
Right, exactly. So I tend to send, the much more sensitive assays because that's how I plan to use it.
That's
Though they know that we're not de-escalating therapy on purpose, but sometimes the patient, essentially she's running her own clinical trial of herself, right? She has to live her own life, and we have to respect that.
Absolutely. And that's one thing that you can do in clinical practice, you can never replicate in a clinical trial.
Right.
And that's the limitation of a clinical trial, which is for an average, but for an individual, you have to look at all this evidence and apply and see what's best for that individual.
Right, absolutely. So going back to adjuvant, DESTINY-Breast05, do you find, in your practice, 14 cycles, right? That's the goal. How many patients do you think get to all 14, right? For TDM1 and for T-DXd. I mean, clearly we don't have as much individual experience with T-DXd yet, given its very recent FDA approval. But with TDM1, do most of your patients get to all 14? Approximately what percentage do you think?
I would say
It all the way
most
there.
90%
Right.
plus are able to complete TDM1.
Right.
And then for TDXd, again, we don't have a lot of experience. My guesstimate would be more like 80 to 90%.
Sure. Right. And, we can adjust doses and all of that. But again, even having some, 14 cycles was arrived at,
Yeah.
it's arbitrary,
Yeah.
right? We're trying to give a reasonable treatment course for patients that receive neoadjuvantly anywhere from 4 to 8 cycles. So we have to kind of make that length a little bit longer, but it's probably fine.
Absolutely. And you have an option. If someone is really, really struggling, man, you can switch to TDM1. The
Right.
side effect is generally
Right.
non-overlapping. And so that's one option to consider.
So then on the flip side, there are some patients that have difficulty tolerating TDM1. Maybe it's LFTs. Something that happens. So would you switch that patient to T-DXd?
Potentially, I would consider that over trastuzumab alone,
Sure.
which in general is not that effective, generally needs to be combined. So if a patient has residual disease and my goal is to prevent recurrence, let's say you started TDM1 and they have neuropathy or LFTs, switching to TDXd is an option.
This brings us to the end of our conversation. It went by too quickly. Thank you so much, Dr. Bardia. It's so engaging to speak with you and hear your thoughts, and I always learn so much and enjoy these conversations. And to the audience, thank you so much for being here, and we look forward to more conversations in the future.